morning, everybody. It's really a privilege to be here today. And given Tom's last statement about being in recovery, I never know kind of whether or not to say this, but I think in this room that I can say this safely. About 26 years ago, I was handcuffed to a hospital bed after being arrested for a drunk driving accident. And it's only fitting that someone gave me a second chance. I think it speaks to the power of what you do and what you can accomplish in this work, and the tremendous hope that we have in terms of turning our criminal justice system around and our public health system around. And I really want to thank Mike for the work that he does around the country, to our partners at the Department of Justice, from the Attorney General on down, and particularly the programs that Denise sponsors and her work around public policy. I just had the opportunity to be with the Attorney General last week, and I said, when our top law enforcement official talks public health, we couldn't really ask for a better partnership, and it's really, I think, emblematic of what our national drug control strategy looks like. So I'm really proud to be here today, I have to give a special shout out, and I think a few of them in the room, my former colleagues from Massachusetts, who worked a tremendous amount in terms of how we dealt with this issue, and just in the spirit of transparency, I had no influence about whether or not Massachusetts gets any grants. They did this on their own. But our office is very proud to serve with our federal partners on the Attorney General's Interagency Reentry Council. The council has expanded access to supportive reentry services through federal grants, engaged in policy changes to ensure support for people returning to their communities, and worked with state and local entities to clarify misconceptions about federal laws and regulations that create barriers to reentry. This administration's commitment to helping individuals being held back due to their justice involvement is unwavering, and I think you heard much of that this morning. When the Office of National Drug Control Policy released this administration's first national drug control strategy in 2010, it fundamentally redefined the way federal government perceives and responds to substance use. I remember being in Massachusetts at the time and heard then Director Kurlikowski, a former police chief from Seattle, tell us that we could not arrest our way out of this problem. The strategy was based on public health and public safety professionals from across the country and on decades of research demonstrating that addiction is a brain disease, one that can be prevented and treated, and from which one can recover. Expanding real evidence-based drug policy and justice reform is a huge undertaking, and one that relies on the alignment of federal, state, and local partners. Your work helps us reach the strategy's criminal justice priorities, avoiding costly and lengthy justice involvement for low-level nonviolent offenders, connecting people with treatment for substance use disorders, and helping to keep criminal records from becoming barriers to individuals who are reentering society and seeking education, employment, and housing. Having spent most of my career addressing public health issues at the state level, I have a special appreciation for your work. As Tom indicated, prior to coming to ONDCP, I served as the director of the Bureau of Substance Abuse Services at the Massachusetts Department of Public Health. Our experience with healthcare reform showed us the potential for expanding access to care for those people who never had regular contact with the healthcare system. While we made significant advances in reducing the rate of the uninsured to less than 2%, a significantly higher number of individuals with substance use disorders, particularly those involved with a justice system, remained uninsured. It was clear that they needed assistance in getting insurance and accessing and remaining in care. Health coverage is a critical piece of reentry support, but we found that it wasn't enough. Justice-involved individuals need additional supportive services to attain and remain in recovery. Many need housing, employment, financial aid for school, and sometimes something as simple as even obtaining a valid form of identification to qualify for health care coverage. If the Massachusetts experience bears out nationally, The expansion of health care through the Affordable Care Act is a great first step, but facilitating links and providing comprehensive support are also critically important to successful outcomes for justice-involved individuals with substance use disorders. We cannot discuss substance use disorders in this setting without acknowledging the prevalence of this disease among those in the criminal justice system, our lack of treatment infrastructure that Tom talked about, and the risk of this severe consequence attached to untreated addiction. Any successful reform program must address substance use disorders as a root cause in the cycle of drug use, arrest, and incarceration. Many of you know the extraordinary numbers of people with untreated substance use disorders in our parole and probation populations. However, less than 20% of each of these actually receive treatment at a specialty program. Individuals with a substance use disorder should be treated obviously within the healthcare system and not in the criminal justice system. But for those already involved, reform efforts supported by the Affordable Care Act must be implemented. By expanding access to and parity for substance use disorder and mental health treatment for an estimated 62 million Americans, the ACA is the most significant piece of drug policy reform in generations. Of the 23.1 million Americans who needed treatment for a substance use disorder in 2012, only 2.5 million actually received the treatment they needed at a specialty facility. That's only 10%. This is absolutely unacceptable. Treatment should not be a privilege limited to those who can afford it, but a service available to those who need it. With the ACA, we have been given the best tool to ensure that people getting the substance use disorder treatment they need by requiring insurance companies to cover treatment just as they would any other chronic illness, thereby ensuring the appropriate resources are available to those who need it. The law requires mental health and substance use disorder treatment as one of the 10 essential health benefits that insurers are required to cover. There is also the significant opportunity to redeploy those resources to expand recovery support services by community organizations. To date, more than 8 million people have already enrolled through state and federal exchanges, and another 4.8 million people receive coverage via Medicaid expansion. In working with justice-involved individuals, you stand at a critical juncture in assisting those on probation or those transitioning back to the community. You can help these individuals get enrolled in health care coverage, connect to services in the community, and receive a full spectrum of substance use disorder services. But it must be quality treatment coupled with a wide variety of recovery support. This can help prevent relapse, can help address people's underlying problems and get them back on track, and help those with substance use disorders maintain long-term recovery. Appropriate treatment and supportive services that pull justice-involved people out of the shadows go a long way toward creating stability. Reducing the barriers of criminal histories and substance use can help people reconnect with their families, engage more fully in their communities, and become productive members of society. That is why the work that you do is so tremendously important. One way to assist individuals in maintaining long-lasting recovery is to embrace effective, appropriate, evidence-based treatment. As Tom talked about just prior to me speaking, many of you are dealing with the consequence of the dramatic increase in prescription drug use issues and heroin use in our communities. Like many chronic diseases, certain substance use disorders can be effectively treated over the long term with the help of medications. Medication-assisted treatment is the standard of care for treating opioid use disorders and includes maintenance and behavioral therapies. The good news is that the Food and Drug Administration has approved 3 medications for the use in the treatment of opioid use disorders: methadone, naltrexone, and buprenorphine, as well as several for alcohol use disorders. Just as a departure, there was a very interesting article in JAMA today that showed very few physicians actually prescribing medications for the use of alcohol use disorders, and we know that the same is true for opioid use disorders as well. As part of the reentry planning, individuals with an opioid use disorder can be connected to an opioid replacement therapy program. Coupled with behavioral treatment and recovery support, it can improve outcome and save lives. Treating opioid use disorders with every tool at our disposal helps us address another growing health issue, and that is one of opioid use overdoses. The Obama administration is working to address the epidemic of opioid use disorders and overdoses through support for public education, monitoring, disposal, and enforcement of existing laws to abate the availability of non-prescribed medications and reduce the misuse of these legal substances. At the federal level, we have developed resources for prescribers. My office worked with the National Institute on Drug Abuse to develop 2 free online tools on safe prescribing for pain and managing pain patients who abuse prescription opioids. These courses provide healthcare professionals with critical skills to manage high-risk patients and prescribe medications more safely. These are all steps in the right direction, but we are still losing far too many people. In 2010, unfortunately the last year that we have complete data, an average of 100 people died every day from a drug overdose. Unfortunately, recent data indicate an uptick in the use of heroin, another opioid involved in a significant number of overdoses. We must focus on preventing overdose deaths. As we have done in identifying the warning signs of a stroke or a heart attack, we can help save lives by recognizing the signs of an opioid overdose and helping victims get help in a timely manner. Education is the first step, but we are also promoting access to naloxone among people who are likely to encounter overdose victims. Naloxone is a medicine that can rapidly reduce an overdose caused by opioids. ONDCP has partnered with law enforcement organizations across the country to promote expanded naloxone access and training on overdose prevention. Where states have equipped police officers and other first responders with naloxone, the outcomes have been nothing short of miraculous. The police department in Quincy, Massachusetts, which is a small town south of Boston of 60,000 residents, partnered with the state's health department to train and equip police officers to resuscitate overdose victims using naloxone. Since October 2010, officers in Quincy have administered naloxone in more than 220 overdose events, almost all of them resulting in successful overdose reversals. You can also support these efforts. Educating on overdose prevention, providing naloxone kits, and facilitating linkages to community-based services can be included and should be included as part of the reentry process for an individual with an opioid use disorder. Those leaving correctional institutions who start opioid use again are among the highest people with risk for overdoses. In Massachusetts, our overdose prevention plan included education for those at high risk of overdosing and linked them with community services upon release. The San Francisco County Jail's HIV and Integrated Services Program provides training on how to use naloxone in the event of an overdose, and it offers naloxone kits to individuals upon release from custody. To sum up, reforming drug policy is a complicated and not always easy task. Moving forward, I hope all of you will continue to be the heroic leaders you are in establishing a more comprehensive system of care for individuals with substance use disorders, advocate for the ability of life-saving measures, and support people re-entering their communities after a period of incarceration. I urge you to consider how you might better connect these individuals receiving services to the benefits of the Affordable Care Act and to improve their overall well-being. I encourage you to incorporate medication-assisted treatment and overdose prevention programming for individuals with an opioid use addiction, and ask you to include solid recovery supports for all justice-involved individuals to bolster their chances of success. Again, thank you for the work that you do, and I look forward to continuing this conversation and working with you to make our country safer, healthier, and more just. Thank you very much.
Thank you very much, Director Botticelli, and I'm delighted that you've agreed to stay for a little bit and take some questions from the audience in case we have any. So we've got, excuse me, a microphone there in the central aisle in case anybody has any questions for Director Botticelli. And while we let folks make their way to the microphone with any questions they have, I'm going to take this quick opportunity to, I'm looking for Robert. I don't know where the slide is, but you'll see, again, that you can join the conversation with us. For those of you who have Twitter accounts, there's hashtags on the screen, and you can use those to join us on the conversation through Twitter. I have no idea what that means, and I've just said, but I'm assuming that some of you in the audience are nodding knowingly, saying thank you, and we'll start doing things on your smartphones as a result. So hope we just sort of had a moment there where we connected. Director Botticelli, a question that I'd like to ask just on behalf of people in the room, and I think that many people are hearing about different kinds of medication-assisted treatment, yet most of us in this room don't come from that world necessarily. We hear about concerns about the costs associated with it. We hear about political concerns and just a general lack of familiarity. What can people in this room do when they go back to their reentry programs to really help increase awareness and familiarity with some of these strategies?
Sure. So a couple things. One is, like any chronic disease, I think of something like diabetes that we treat with insulin. There's a significant amount of myth and misunderstanding attached to medication-assisted treatment. And, I often hear people say that, oh, aren't we just substituting one drug for another? Which is really not the case. I think if folks have a chronic disorder, that we know medication-assisted treatment is probably the most effective tool in actually keeping people with opioid use disorders engaged in their care. It can be challenging, and I think it's very challenging, particularly for correctional institutions, to introduce that, but also connecting to folks on the outside. But I will say that there's many projects that are happening around the country, in Rhode Island and other places, that are connecting people to those support services. And one of the things that I think has been helpful, particularly for justice-involved folks, is one of the newer medications that we have, naltrexone, which is an injectable drug. Right, and so what it is basically a 30-day injection for opioid use disorders, and that many people have found helpful with a correctional population. So part of it is, I think, establishing good relationships with community-based providers who are doing this work, looking to models around the country for correctional facilities who have implemented this work, I think has really shown significant success in meeting both our public safety and public health goals in the work that we're doing. These are tremendously misunderstood medications, and I think the first thing people can do is just really get educated about what these drugs do and what they're not. And I think that that's always a really good first step in the work that we do.
Thank you. Is this microphone on? Yeah. So thank you very much. Two quick observations. One is there will be a panel during the course of the conference. We're thrilled to have the director of the National Institute of Drug and Alcohol Abuse, and I believe she'll be talking more in detail about some of these strategies that the Director Botticelli is talking about. So encourage folks to go to that particular panel. Secondly, want to make sure that all of the great resources that you're talking about that are available through ONDCP are made available on the National Reentry Resource Center website. We'll certainly take steps to do that. One other question, if I may. I guess I'm sort of excited here. I get to ask all the questions, seeing that no one else is taking us up on the opportunity. And that is, you mentioned the Affordable Care Act. And I think Tom Stickrath mentioned earlier that especially in rural communities, the frustration that the treatment capacity isn't there. And we often hear the capacity's not there because the dollars aren't there. And I know through the Affordable Care Act, people talk about by increasing coverage rates, we'll see more availability for treatment. But again, for many of us not from this world, this is really complicated stuff. Sure. So if you could advise folks in recognizing that every state's in a different place in terms of its adoption of provisions in the Affordable Care Act, what are the 1, 2, or 3 things that you think they should be making sure they do when they return to their states and counties vis-a-vis the Affordable Care Act?
So I think there are a couple things that are particularly important at the state level that are state-level decisions as it relates to the Affordable Care Act. One is, what is the set of benefits that are being offered through state exchanges, and quite honestly through your Medicaid office to do that. My experience in Massachusetts was, we had a pretty significant Medicaid benefit that provided for a wide variety of treatment services, including all of the approved medications. So really finding out of what benefits are offered, and really talking if there's any way that you can promote a significantly robust benefit. I think the other piece is important, and Tom talked about this in terms of working with both your substance abuse authorities and your mental health authorities in terms of what are the services that are available that's out there. Again, my experience in Massachusetts is that we get funding from a wide variety of sources, including the Substance Abuse Mental Health Services Administration in the form of a block grant. And what the Affordable Care Act allows states to do is redeploy money that they were previously spending on treatment services and redeploy those dollars into a wide variety of services that insurance does not pay. So things like housing searches, employment searches, and even paying for housing in some of those situations. I think the second piece, and again, Tom alluded to this, is how do we provide good integrated behavioral health and primary medical care services? And one of the opportunities that I think we have going forward is how do we work with our primary care people, particularly our federally qualified health centers, in looking at and can provide valuable reentry services for people coming into care. So, and I think that's particularly important where we can't build bricks and mortar treatment programs in rural areas. So how do we use our existing infrastructure and use the fact that more people will have coverage to provide services through the infrastructure that we already have available to us?
So when you know it, Director, now we have a queue building up in the middle. So we have just a few minutes left. If you could introduce yourself and you have a question, ma'am.
Yes, my name is Carol Leese, and I'm with the Empowerment Program in Denver. We work with a smart probation program. And if you could give me your comments on the value of syringe exchanges in the whole harm reduction approach to decreasing use of drugs.
Sure.
Thank you.
Great. And having come from Massachusetts, I think I have some opinions on that matter. One of the things that we hear with, and I hate the phrase harm reduction because it just sets off alarm bells for a lot of folks. I feel like we have a responsibility as a federal and state government to protect our most vulnerable citizens from death and disease. And I think one way we know, and has been proven to do that, is by things like making sure that people who are not ready for treatment have access to sterile syringes to avoid the issues that we have with HIV and hepatitis C. One of the things that Tom talked about is the burgeoning opioid heroin issue that we have here. And one of the things that we're seeing is a resurgence of HIV and viral hepatitis among these very young injectors who started using prescription drugs. So, unfortunately, Congress doesn't agree with us. And despite federal policy, including a national drug control strategy that endorses syringe exchange programs, has continued to institute a ban on federal funding for syringe exchange. The other issue that we hear, both quite honestly in terms of syringe exchange and in terms of overdose prevention, that aren't we just perpetuating drug use by saving people's lives? And the way that I frame this is, if you had a heart attack and you didn't stick to your diet, would we say, we're not going to resuscitate you because you haven't sticked or you're not committing to treatment? And we don't do that. We don't do that with any other chronic disease. We do everything in our power to reduce the harms associated with it. And the last thing I'll say is that there is no evidence to suggest either syringe exchange programs or naloxone distribution programs actually continue to promote and expand drug use.
Two more questions and just a couple minutes left. Yes, sir.
Yes, my name is Mark Olson from Aurora, Colorado. We have a Second Chance Act thing with that. But your comments regarding rural care, one of the things that I know is problematic in our state, Colorado, is there are a lot of rural areas, and it's spread out all over to the point where trying to find providers, sort of boots on the ground kind of scenario, to deliver treatment to people in rural areas is very problematic. I myself get calls on occasion from Wyoming, from people up there who are looking for care because they cannot find it in the towns they live in Wyoming. Is there anything in the federal government or BJ, OJJP in terms of looking at strategies to get more providers out in those areas?
We've actually been working with HRSA and our other partners to really look at how do we expand I think there's some things that you can do at the state level too, right? I'm a state person, I think there's things that you can do. So how might you work with your medical society in the state to get more physicians to be trained to administer buprenorphine? I think that, we have too few doctors who have kind of stepped forward to say, you know what, I'll treat people with addictive disorders. So anything you can do at the state level to promote physicians, it's really minimal requirements. It's about 8 hours of training from the DEA to be able to do that. Again, I think, how do we utilize some of our primary care infrastructure, and particularly our community health centers, is a good way to do that, and we're looking at federal opportunities to be able to do that. There's actually a hearing later on this afternoon from the Senate Drug Caucus, and one of the things that we're interested in is looking at how might we get some enhanced federal resources to expand access to medication-assisted treatment in substance use disorders through our primary care system. I think the other piece, and the last thing I'll say is, and Mike talked about this, and I don't know what the average age in the room is, but there are a lot of younger folks out there who use technology in very significant ways. And I think one of the things that our office is invested in is how do we use technology? How do we use apps? How do we use video conferencing? And I visited West Virginia, who has a rural access issue, and they are actually using telemedicine with their federally qualified health centers as kind of treatment extenders for those populations. So I think we have to think of all of those different strategies.
Thank you. Last question.
Well, good morning. And first of all, let me say in transparency that, I'm sorry. Typical me.
Thank you. Yes, sir.
Sorry about that.
I apologize. First of all, good morning. And before I ask my question, I want to say thank you for your transparency here. I think when you spoke of, your recovery process and where you've come from, you're speaking to millions of people in the country who need to hear that from our leadership. You're a real person, and that speaks to your leadership skills. So thank you on behalf of us in recovery who salute you for your transparency this morning. One of the problems I'm having in the Second Chance program out of Racine, Wisconsin is that we struggle getting corrections to kind of believe in the medical model for addiction and dependency. I've had people who are being sanctioned and in some cases revocated because of opioid-related substance use. How can we get corrections to kind of respect the fact that there is a medical component, that when providers are making recommendations for a higher level of care, that it's not just kind of dismissed and treated as a behavioral issue?
I'm not sure I have all the answers for that. But again, I think that, part of this is about relationships, and it's about partnerships. So how do you create those opportunities either through state panels? So Tom talked about many states have substance use task force that exists at the governor's level that really require those kinds of partnerships between correctional facilities and the public health departments that do that. Again, I think part of what the Second Chance Act does, as well as larger policy issues, really require that kind of partnership between the correctional folks and the health departments and the substance use agencies. I think part of what we have to do, our job is to show them the evidence of the effectiveness of this. I think everyone is looking at what are the opportunities here to really have effective treatment. So I think, and I always felt that this was my job at the state level, is to really promote the evidence and the models that show that this works. We can continue to do that at the federal level. So how do we create those kind of partnerships with the correctional medical agencies that are doing this kind of work? So we'll try to continue from a policy and practice level to continue to support that work.
Thank you, Director Botticelli. Director O'Donnell, you wanted to make a comment.
Sure. I just want to underscore the fact that many of you know that there's a BJA policy that allows you to use your Second Chance Act grant funding and many of our other grant funds in order to provide guidance and provide support for connecting individuals to healthcare coverage. And so that's an important new area in which grant funds can be used, and we are collecting performance data regarding that from you to let us know whether you are using funds in that way as part of holistic reentry services. We think it's an important opportunity that we have now under the Affordable Care Act, and hope that you will be building that in as part of your reentry strategies for your programs. Thanks.
I'll just also add an important point that Denise brought up in terms of how you use these conferences, that they really are a really great opportunity to connect with some of your peers in other states who can give you some lessons learned in terms of what they saw as successful strategies and successful partnerships. So I think the value of these grantee meetings is that you have colleagues in other states and other jurisdictions who may have made progress in those areas, and talking with them and understanding kind of what they did what they did strategically to help reinforce those partnerships, I think is one of the meaningful ways to use conferences like this.
What a terrific springboard to many hours that we have now in front of us about all these different issues. Please join me in thanking Director Botticelli, Director O'Donnell, and Superintendent Stickrath.